Bismillah ar-Rahman ar-Rahim. Actually, if you know perfectly the anatomy, the pathology will be very easy of the Petrous bone. Then we start, as we started by the anatomy of the external ear, we started by the pathology of the external ear, and we have the two major issues. The first one is the atresia or hypoplasia of the external auditory canal, and the second one is malignant otitis media, otitis externa, which is the inflammatory process of the external auditory canal. Actually, the atresia of the external ear is presented into two types: the soft tissue atresia and the bony atresia. In the soft tissue atresia, you can see the external auditory canal, which is filled by soft tissue structure. And the role of images in both types of atresia, the bony one and the soft tissue one, is to assess the middle ear cavity and the ossicles in particular. And in this example, you see the axial images. The external auditory canal is blocked by soft tissue, and the ossicles are represented by a deformed, fused bony ossicle, single ossicle. Then this should be reported that the ossicles are not presented in the usual ice cream cone, but they are fused and deformed. Then in the bony atresia, you cannot see any external auditory canal. There is only bone underneath the skin, and there is no canal at all. In the same way, you should report about the abnormalities in the ossicles if they are fused together, and sometimes they are also fused to the inner bony wall of the middle ear cavity, as seen in this case. And you can also note that this arrowhead points to the dome of the cochlea, and this is the cochlear nerve, and this is the vestibule, and this is the lateral semicircular canal. Then, in this patient, the extended canal on the right side is normal. On the left side, it is present but blocked by soft tissue structures, which represents the soft tissue atresia. Here you can see the right extended canal is normal, but here you cannot see any extended canal. You can see only bone and the subcutaneous tissues. This is bony atresia of the extended canal. And malignant otitis externa means an aggressive inflammatory lesion affects the extended canal, and the mastoid may extend inside the middle ear cavity. Is usually seen in diabetic patients and any immune compromised patient, either for diabetes or because of age or because of cancer and so on. Then what you can see in the CT is destruction of the extended canal, which is totally obstructed by inflammatory granulation tissue, and the adjacent bones may be eroded, like the head of the mandible. The soft tissues are infiltrated by heterogeneously enhanced inflammatory granulation tissue. Then the diagnosis is easy if you know actually the history and the patient condition. Then some of the neoplastic lesions which may occur near the extended canal include the osteomas, which are known in the calvarial bones. Also, fibrous dysplasia may affect the whole petrous bone and the temporal bone as well, and may affect the middle ear cavity and the ossicles. Then the cutaneous malignancies like basal cell carcinoma or squamous cell carcinoma, adenoid cystic carcinoma, and the others, also metastasis, can occur in this particular area. Then we came to the middle ear cavity, and this is one of the abnormalities which can be commonly seen in the clinical practice, which is the anomalous course of the internal carotid artery. This is the normal carotid canal in relation to the middle ear cavity, and this is the abnormal course of the internal carotid artery near or very close to the middle ear cavity. Then if you do an MR angiogram, you can see the abnormal course of the carotid on the right side corresponds to this anomalous appearance intimately related to the middle ear cavity. Then to diagnose otosclerosis, you just see that the oval window is obstructed by bone. If you look here, this is the normal oval window, and here the oval window is totally blocked by bony ridge, which is diagnostic of otosclerosis. Also, sclerosis may occur in any of the structures of the inner ear. Then at that time, you may diagnose labyrinthine ossification, Like this arrow points to the dome of the cochlea, which is ossified compared to the dome of the cochlea on the left side, which is normal. And this is the canal for the cochlear nerve. This is the canal for the cochlear nerve. Then one of the famous diseases of the middle ear is cholesteatoma, either the congenital type or the acquired type. The difference between both is that congenital cholesteatoma occurs in a clear, healthy middle ear. There is no previous history of otitis media, and the mastoid ear cells are usually clear. The diagnosis of cholesteatoma is based on two major criteria. The first one is a non-dependent soft tissue lesion inside the middle ear cavity, which does not change by the change of the position of the patient. Number two, no enhancement. And this is very important, that cholesteatoma does not enhance with contrast material, and cholesteatoma is a non-dependent opacity. I didn't mention anything about bone erosion or ossicle destruction or any other findings, but these are the only two major criteria for cholesteatoma diagnosis: the non-dependent opacity, which is not enhancing. Then this opacity is considered congenital cholesteatoma whenever the middle ear cavity is clear, there is no previous history of otitis media or mastoiditis. And the congenital cholesteatoma commonly occurs near the stapes or near the Eustachian tube, but any place can occur, like this one near the Eustachian tube, for example, and this is another congenital cholesteatoma, and this is also another congenital cholesteatoma. Then in order to know that this opacity is dependent or non-dependent, you should have some air inside the middle ear cavity in order to see the relation of the air to the soft tissue. If you don't have any air inside the middle ear cavity, you cannot reach a conclusive diagnosis. And the books said that total opacification of the middle ear cavity is of no diagnostic value. It can happen with otitis media, and it also can happen with cholesteatoma. Then at that time, you may depend on ossicular erosion and destruction of the walls of the middle ear cavity in order to suspect the possibility of cholesteatoma, because you know that both otitis media and the cholesteatoma do not enhance with contrast material. Then if you look here, and you can see inside the middle ear cavity, this area is aerated, but the mastoid antrum is opaque. And also you can see opacity here, and you can see opacity here. Then, what do you think about this lesion? Do you think it is cholesteatoma or otitis media? You don't know. You should put the patient in the true prone position and scan him once more. If this opacity is non-dependent, then you know that this is cholesteatoma. If it is dependent, meaning fluid, then this is otitis media. Then can you say for sure this is otitis media or cholesteatoma? Yeah. What do you think? Yes, this is cholesteatoma because of this appearance. This is the non-dependent opacity, number one, and the marked destruction of the bony walls of the middle ear cavity, and also the destruction of the ossicles. This is another case of cholesteatoma with destruction of the mastoid antrum and the mastoid air cells. Then the acquired cholesteatoma, or what we call the pars flaccida cholesteatoma, or the Petrous space cholesteatoma. What is the Petrous space? The Petrous space is the space between the ossicles and the lateral wall of the middle ear cavity. And if you look here in this axial image, you can see these are the ossicles, and this is the lateral wall of the middle ear cavity, and this area is known as the Petrous space. Then, if you want to diagnose this as Petrous cholesteatoma, it's okay, but this is cholesteatoma. Why? Because it is a non-dependent opacity and it does not enhance. Then the sinus cholesteatoma occurs in the sinus tympani, which is adjacent to the facial nerve, separated from it by the tympanic pyramid. Then here, can you see this cholesteatoma occurring in? No. No. It is not in the sinus tympani. Yes, it occurs in the facial recess. This is the sinus tympani, which is clear. And this cholesteatoma hit the facial nerve canal. And this patient should complain of facial nerve palsy because the cholesteatoma is centered to the facial recess. Then here, the cholesteatoma is located high in the middle ear cavity, in the attic. And it is subjacent to the tegment tympani. One of the complications is erosions of the tegment tympani and the extension of the inflammatory material intracranially. Also, one of the complications is erosion of the semicircular canals. The lateral semicircular canal is the nearest one to the middle ear cavity. The lateral semicircular canal is the nearest canal to the middle ear cavity. Then it will be eroded, and at that time you can easily diagnose what we call labyrinthine fistula, which means communication between the inner ear and the middle ear. If the cholesteatoma has eroded usually the lateral semicircular canal, you are dealing with a labyrinthine fistula. Then this is cholesteatoma that has eroded the tegment tympani with intracranial extension and abscess formation in the temporal lobe. It is a frequent complication of cholesteatoma. And this is the same case in the coronal view, showing the erosion in the tegment and the abscess, which is related to the temporal lobe. Then congenital cholesteatoma, sorry, this is not congenital, this is what we call the glomus tympanicum. This title is wrong. Glomus tympanicum is a vascular lesion inside the middle ear cavity. And this lesion simulates actually the cholesteatoma. But the only difference is this is a vascular lesion that can enhance if you give contrast material. Then it is easily diagnosed by the physician looking inside the external ear behind the tympanic membrane, and you can see reddish swelling, which is easily interpreted as glomus tympanicum. And if you look here, this is the soft tissue density, which is non-dependent in the middle ear cavity. If you inject the contrast and the lesion enhanced with contrast material like this in MRI, this is CT and this is MRI, then you can reach the diagnosis of glomus tympanicum. This is another case of glomus tympanicum located in the middle ear, and after contrast injection, the lesion has enhanced, denoting the glomus tympanicum. And anyone looks at this lesion, he may say that this is a cholesteatoma. But in order to differentiate cholesteatoma from glomus, radiologically, you should inject the contrast material. This is one of the indications of injection of contrast material while examining the Petrous bone. Then you know that there are two types of fractures affecting the Petrous bone. The longitudinal one, which affects the whole length of the Petrous bone, and the transverse one, which is a vertical fracture affecting the Petrous bone. The longitudinal fracture is much more common than the transverse fracture. And the longitudinal fracture usually affects the middle ear, while the transverse fracture usually affects the inner ear structures. Then, if you look to this fracture, which is passing across the whole length of the Petrous bone, this is a longitudinal fracture, it affects the middle ear cavity. Then what do you see in the middle ear cavity? If you look to the ice cream cone, you can see only the ice cream, but you cannot see the cone. Then there is dislocation of the oncodomalleal joint and the displacement of the incus, any place inside the mastoid or the mastoid antrum. And this is the horizontal, or as if this is the transverse fracture of the Petrous bone. And you can see the fracture line which passes across the Petrous, and it affects mainly the inner ear structure. These are the two limbs of the superior semicircular canal. It also affects the, it also affects the vestibule. Then, if you look inside the middle ear cavity, and you can see that the oncodomalleal joint is slightly widened, then you reach the diagnosis of subluxation of the oncodomalleal joint post-traumatic. If you look inside the inner ear cavity or the middle ear cavity, and you can see air in the vestibule, then you know that this is pneumolabyrinth, which is a post-traumatic complication. In the middle ear cavity, you can see air fluid level. And this fluid is, of course, secondary to trauma, meaning it is blood. Then this is hemotympana. Okay, what do you think about this encodomalial joint? Dislocated. And what do you think about this incus and the malleus, and malleus and the incus? Total dislocation of the encodomalial joint with displacement of the incus in the mastoid antrum. Then finally, you came to the inner ear abnormalities. Starting with the congenital abnormalities, and you know that the endolymphatic duct and the sac, what we call the vestibular aqueduct syndrome, is one of the most common causes of sensory neural hearing loss. And one of my advices to you is whenever you are interpreting an examination of the Petrous bone for the possibility of a cause of a sensory neural hearing loss, revise many times the area of the vestibular aqueduct. The normal vestibular aqueduct is about 1.5 millimeter in diameter. This is the normal one. If it is larger than this, you can easily diagnose this syndrome, which is known as the vestibular aqueduct syndrome or large endolymphatic duct and sac. Then this is the syndrome by CT and by MRI. By MRI, you can see the sac itself containing the endolymph. Then this is the vestibular aqueduct, which is markedly widened, and here is the vestibule and the posterior semicircular canal. Then abnormalities in the inner ear may include two main categories. This is common, the Mondini anomaly, and this is very rare, which is the Michael-Michael anomaly or Michael anomaly. The Michael anomaly or Michael anomaly means total aplasia of the inner ear. There is no inner ear structures at all. But the Mondini anomaly is morphologic abnormalities in the cochlea. You know that the cochlea is composed of the dome, 1.5 turns, and the basal cochlea. And it happens sometimes that the cochlea as a whole is just a single sac. Then this is known as Mondini anomaly. And this Mondini anomaly may affect also the semicircular canals. This is the Michael anomaly. This is the only case I have met in my life. And this CT scan shows that there is no any inner ear structures. And in order to confirm that, you may have an MRI, and the MRI is very good for detection of the middle of the inner ear and is not good for assessment of the middle ear because of the air. Then you can not see any traces of any structure of the inner ear. Then this is the Michael anomaly, and here is the Mondini anomaly. This is the vestibule, which is markedly widened. Mondini actually refers to abnormalities of the cochlea, but these abnormalities can be associated with abnormalities in the vestibule as well as in the semicircular canals. Then this is the dome of the cochlea, which is normal, and this is the dome of the cochlea, which is markedly enlarged. This is the canal for the cochlear nerve, and you can see the dome of the cochlea is ballooned. Also, the vestibule here is widened, but the vestibule here is normal. Mondini anomaly may be bilateral and may be unilateral. Then the semicircular canal may be short, like this one. This is the normal width of the semicircular canal, but this canal is relatively shortened, and the vestibule is relatively widened, and the vestibular aqueduct is dilated. The internal auditory canal may also be dilated without any intracanalicular tumors, and this is known as mega internal auditory canal, which may be unilateral or bilateral. This is the normal configuration of the internal auditory canal. Then you came to a famous syndrome, which is nowadays discussed clearly in the literature, which is known as the superior semicircular dehiscent syndrome. You know that this is the vestibule, this is the lateral semicircular canal, and this is the superior semicircular canal. And the superior semicircular canal should be separated from the brain by bony ridge. If this bony ridge is absent, you know that the syndrome, what is called as the superior semicircular canal dehiscent syndrome. Then what happens in this dehiscence? If the vibrations of the waves hit the tympanic membrane and they are transmitted through the ossicles, to reach the oval window. Then it will hit the endolymph, and this will increase the pressure in the endolymph, which will be absorbed at the round window. Will be absorbed at the round window, اللي هو the connection of the basal turn of the cochlea to the middle ear cavity. But whenever this membrane, this part is dehiscent, there will be what we call a third window. You know, an oval window, a round window, and this dehiscent, which is a third window. This will result in vibration of the fluids inside the semicircular canals. And this is interpreted by the brain as the patient moves. Then whenever you are speaking loudly to the patient, he got dizzy and fainted. This is in a simple way, what we call the superior semicircular canal. Sorry, you understand this? Okay. Especially if he has this syndrome, okay. Then what our role in diagnosis is just to look like this. We used to do nowadays, if this is the possibility, we do a special sections for the semicircular canal to see the whole superior semicircular canal. Then this is the oblique sagittal view, and you can see the whole superior semicircular canal. But here you can see the superior semicircular canal. The upper part is dehiscent and is connected is directly related to the brain. Then the facial nerve schwannoma is one of the lesions that can be seen in the examination of the Petrous bone. This is the canal of the facial nerve, the normal canal of the facial nerve. If you see this examination, and you can see a soft tissue density which is non-dependent, and you diagnose the common lesion, which is the cholesteatoma. But in order to diagnose this as facial nerve schwannoma, it should enhance with contrast material. If you inject contrast and the lesion is enhanced, then you are dealing with facial schwannoma. And this is an enlargement of the facial canal, the ascending limb, and by MRI you got thickening of the facial nerve and the enhancement of the facial nerve, diagnostic of facial schwannoma. Then the facial neuritis is an inflammatory reaction which is referred to as Bell's palsy, and this can be diagnosed by MRI if you inject contrast material and you got enhancement of a normal sized facial nerve. If the facial nerve is swollen, then you are dealing with neuroma. If the facial nerve is of normal caliber, you are dealing with facial neuritis. And in the coronal image, you will see these two dots which correspond to the tympanic and the labyrinthine segment of the facial nerve, what we call in MRI the snake's eye appearance. The last issue is the cochlear nerve atrophy, which may be secondary to vascular insult or inflammation or trauma. And you can easily diagnose this in the sagittal T2 MRI. You know that the two nerves close to each other are the vestibular divisions. The upper one is the facial nerve, and this is the cochlear nerve. Then if you scan the internity canal and you found this nerve is missing, you can easily diagnose cochlear nerve atrophy. And this is an easy diagnosis by using the MRI sagittal T2 weighted image. Then you came to the questions. What do you think about this case? Malignant otitis externe. Any other possibilities? يعني ايه external cholesteatoma? Okay, if you look here, this is the middle ear cavity, and this is the mastoid ear cells, and this is the ossicles الموجودة هنا الصورة صغيرة شوية, and the lesion is destroying the mastoid antrum and extending into the middle ear cavity, and this is cholesteatoma, acquired cholesteatoma. Okay. The arrows point to these arrows. Fracture, which type? Yes, the transverse type. The transverse fracture affecting the facial nerve canal with hemotympana. What about the ossicles? Hemotympanum because of the fluid present in the middle ear cavity. What about the ossicles? They are not seen. They may be dislocated or may be seen in another section. What does this arrow points to? Air inside the internal DT canal. Very good. What do you think about this case? Atresia on one side. Which side? Left side. Bony or soft tissue? Yes, this is bony atresia of the left extended canal. Anatomy. What do you think about this structure? This is above the ice cream cone or below? Above. This is the epitympanum, okay? This is the epitympanum. And this? Superior semicircular canal. And this? Tegment tympani. What do you think about this case? Fibrous dysplasia of the left petrous bone. Very good. Yes, this is a brain abscess complicating otitis media and mastoiditis on the right side by MRI. What is the diagnosis? Cholesteatoma. And the arrow points to? Erosion of the, which semicircular canal? This one? The lateral. Erosion of the lateral semicircular canal, which is diagnostic of labyrinthine fistula. Anatomy. What is this structure? Attendic canal, and this is vestibular aqueduct. Very good. And this is posterior semicircular canal, and this head of the malleus, and this lateral semicircular canal. What do you think about this case? Yes, this is the superior semicircular canal dehiscent syndrome. Very good. Longitudinal fracture ومعاه four other lesions. Number one, subluxation of the oncodomalial joint. Number two, hemotympanum. Very good. Number three, labyrinthine fistula. Very good. Labyrinthine fistula, the lateral semicircular canal is directly connected to the middle ear cavity. And the fourth one? What is this? Air in the cochlea. Yes, this is the dome of the cochlea containing air, and this is pneumolabyrinth. Then you have hemotympanum, subluxation of the oncodomalial joint, labyrinthine fistula, and pneumolabyrinth. And thank you very much.